Over to you.
Sakina, thanks very, very much. Yes, indeed, that's where we are this morning in the Northwest, and certainly a very, very hot day here as the health professionals from the respective African countries are gathering here in Sun City to discuss very pertinent issues that basically make the health sectors up to the standards that they are within the African continent, and ensuring that each country is here to discuss the kind of service levels that the health practitioners have to abide by when they operate in their certain countries. And this affects all those that work within the medical fraternity as well as the dental fraternity as well. So it's a highly important particular gathering that is taking place. I mean, we've got the health minister, who actually, our health minister, Dr. Joe Pahla, who opened up this conference yesterday. I think there was a ceremony that was held last night. We've got health ministers from different African countries. I'm told that the health minister from Namibia, Zimbabwe, Malawi, Kenya, Ghana, just to name a few, are in attendance, as well as 24 other representatives from countries that are on the continent. So this is a very big gathering and an important gathering of its kind. So let me introduce my next guest to you, because like I say, there are lots of people gathering here from the continent, and it's a great pleasure to welcome Dr. Daniel Yumbya. He is the Registrar and CEO of the Kenyan Medical and Dental Practitioners Council. Great to have you, Dr. Yumbya. Thank you very much for talking to us this morning.
Thank you very much.
So Kenyan participation in AMCOA, just talk to us about sort of, obviously you've been a part of it from the very beginning and formation 24 years ago.
Yes, thank you very much. I think as a country, Kenya, we've greatly benefited in the 24 years that we've been members of AMCOA. It started as AMCOSA, Association of Medical Councils of South Africa. We joined in, it became AMCOA. And what we do is that we share best and worst practices in the health sector. So besides sharing best and worst experiences in the regulation of healthcare, we also develop protocols. For example, the first protocol that we developed some years back is a protocol on the training of interns, because when doctors complete their training program, they go for apprenticeship, a period where they go through hospital experience and exposure to patients. So we developed a guideline, and that protocol, each country made and customized it to meet their own country expectations. That's one. And the other protocol that we developed is that one of information exchange. What kind of information can we share that within our sectors? And that is basically what we did. And that some of the information that we share is about practitioners who would like to move from one country to the other. And we realize that without guidelines on how these people move, some of them have medical malpractice cases and they move to other countries to go and practice there. So with that kind of policy, we stopped that kind of a practice, and therefore a health practitioner cannot move from one country to another when they have already been deregistered or they have been suspended from practice. Yeah. So that's that. And then we had a challenge on dual practice, where doctors are practicing they are employed by government, and they're also working in their own individual clinics. That is dual practice. And some countries are very strongly opposed to that, while some other countries have opened that kind of practice. So we realized that as regulators giving two licenses to an individual, one to work in government, the other one to work in private part-time, was not good at all. So our recommendations were very simple, that we need to give the license for a general practitioner and a license for a specialist practitioner, but it's upon the employer now to give them permission, as opposed to the regulator tying themselves, saying they are giving you a part-time private practice license so that you can work over the weekends. That has really assisted, and in Kenya we did that. The other issue that we talked about, and we developed a protocol on disciplinary processes for medical malpractice. So we categorized the medical malpractice instances that we can quantify them to be medical malpractice cases, or that may warrant inquiries. And then we developed the processes of inquiry, that you cannot make a decision on alleged medical malpractice to a practitioner until you have heard what is it that they want to put in their case. Because initially, most countries would sit in their boards, in their committees, disciplinary committees, and make decisions. And these decisions would be made without asking the practitioners to defend themselves. So that we harmonized, and I think that really helped. And HPCSA is a leading regulator in the region in terms of the disciplinary processes for practitioners, because they do have a committee that we have all adopted, particularly in Kenya. We adopted the Professional Conduct Committee. That Professional Conduct Committee is constituted on need-arise basis, and in the region where the medical malpractice case has happened.
So if I can ask you about that particular, if there is malpractice that has been, a charge laid against a certain medical practitioner, is this available to the member countries? So if that doctor wants to come here to South Africa and wants to practice but has a black mark against his name in Kenya, will we be able to pick that up and automatically say, no, you cannot practice here?
Yes, what we do is that we communicate. The effective information exchange is regularly. The registrars have got a forum, and in this forum that we give this information. But you realize we have a secretariat in HPCSA. Therefore, what happens is that if a doctor has been removed from the register, we inform our secretariat, and the secretariat circulates that information to member states. Therefore, upon application for the license, you'll be told, oh no, we still have a pending case, and therefore we cannot allow you to do that.
So this is something that is available to
very, very useful to us, to all of us.
Very important.
In Kenya, we had a doctor from Sierra Leone who was trying a Kenyan who was trying to practice in Sierra Leone, but we gave information. Another one went to Tanzania. Another one came here to South Africa. So we exchange information, and such practitioners are barred from being licensed in the other institutions. We also introduced a certificate of status. This certificate of status, you cannot go to any particular member state and practice without getting that certificate of status. And we do have our sample signatures in the partner states. So you present the document. If it's forgery, they will check against the people that we have issued certificate of status, and we do indicate the purpose under which you need the certificate for, and therefore we cannot allow people to move without being looked at.
Dr. Letlapa was talking to some of the difficulties that medical practitioners have been going through, and none of these are new. Long hours, too many patients to see, access to medical care. Obviously, doctors are working shifts that are ridiculous amount of hours. I mean, as he was alluding to, a pilot cannot fly for a certain amount of hours because things will go wrong. Now, a doctor operating for the amount of hours because there is a desperate shortage of medical practitioners is also an accident waiting to happen. So what are the kind of things that we are going to be discussing here today?
I think we are going to talk about health workforce, and the health workforce begins with the training. How can we increase our training institutions, and how can we have more doctors trained within the institutions where they work in? We're looking at collegiate kind of training. In collegiate training, a general practitioner would be trained by a specialist in a particular hospital. Probably if you are a surgeon, you like to do surgery, you'd be trained by a surgeon within the hospital that you work in, which means that that practitioner will not move out of their their workstation to go and join a university. So these are the ones we call like COSEXA, a College of Surgeons for East and Central Africa. Those are the collegiate training programs that we are encouraging so that doctors' shortage can be minimized. Number two is for governments to increase funding in the training for health practitioners, that each country should increase their budgetary allocation so that the doctors that are trained within a particular year can go up, because if you train more doctors, that would be good for the country. However, we also have a challenge. We've got health work migration. And we did work on this health work migration protocol. We realized some of our doctors are moving, they are migrating from one region, even in-country migration. You could find a doctor migrating from Cape Town to come to Sun City, and migrating from Pretoria and going to Cape Town as well. So this is in-country migration. But we also have out-country migration, where doctors move out of their regions. Some move from Kenya, they go to UK, others also come here in South Africa. So we are looking at the reasons why they migrate. And in particular, I'll be talking about health work compensation. What is it that we are doing to our doctors? How is a doctor paid in Kenya and in Tanzania, in Ghana and in South Africa? So that we attract them, because besides pay, we also need to give them probably transport allowance, we need to give them housing allowance, and we need to give them non-practice allowance so that we can attract them and retain them. Otherwise, in as much as we have many doctors, some are also moving out of the countries, going outside to Europe in search of greener pastures, so they say.
Yeah, indeed, so they say.
So they say.
So, and then some come back because they realize actually it's probably
actually
better
in
at home.
Kenya now we get quite a number coming back.
This is a good thing.
And yes, a good thing for people to come back. And it also came up during the COVID pandemic. Those countries in Europe were hard hit. And you remember in Africa, we had that strong protection. Therefore, those who had moved, now some of them are also coming back home so that they can get into their systems.
Well, it's been a pleasure speaking to you. And I know that I think you've set us up for our next guest, who is from Ghana. So we'll be chatting to the Ghanaian Medical and Dental Council. And I'm looking forward to that conversation with Dr. Daveen Banyubala. So we can take what you're talking about and sort of compare it with what's happening in Ghana. But I'm realizing that this is a common theme that seems to be running across the African continent. And that's why this gathering is taking place. Pleasure speaking to you, Doctor.
Thank you. It's a pleasure.
And thank you. It's good to have you here in South Africa. Dr. Daniel Yumbya is the Registrar and CEO of the Kenyan Medical and Dental Practitioners Council, all gathering here today until, I think it's until Wednesday, where they'll be talking about issues that are affecting health practitioners and dental practitioners on the continent.